Hi, this is Dr. Akhtar Amin. Today's topic is contact lenses. Therapeutic uses. So, the benefit risk balance, it should be considered in each case because the risk of fitting contact lens to already compromised eye are greater than with lens wear for cosmetic reasons. So, the benefit risk balance should be considered in each case individually. With education, regular review to ensure early diagnosis and treatment of complications. Choice of lens type is dictated by the nature of the ocular pathology. First uses are optical indications. Optical uses. So the optical indications are aimed at improving visual acuity. When this cannot be achieved by spectacles, in certain circumstances, like for example in irregular astigmatism, which is associated with keratoconus, so it can be corrected with rigid contact lenses. After spectacles have failed and before corneal grafting becomes necessary, so patient with astigmatism following corneal grafting may also benefit. Next uses superficial corneal irregularities. Superficial corneal irregularities can be neutralized by rigid contact lenses. They provide a smoother and optically more regular surface. Visual acuity can only be substantially improved if irregularities are not too severe. Another uses for anisometropia, in which the binocular vision cannot be achieved by spectacles due to anisoconia. Which such as may occur following monocular cataract surgery with high refractive error correction. Other uses, contact lens uses are for promotion of epithelial healing. For example, in persistent epithelial defects, they often heal if the regenerating corneal epithelium is protected from constant rubbing of the lids. So contact lens allows the development of hemidesmosomal attachment to the basement membrane. So contact lens, when placed, there will be regenerating of the epithelium because there will be the regenerating epithelium will be protected from the constant rubbing of the lids. Another use is recurrent corneal erosions. They are associated with basement membrane dystrophy, require long-term contact lens wear to reduce the recurrence rate. Post-traumatic cases, lens wear can usually be discontinued after a few weeks. Lens wear also improves comfort. Contact lenses are used for pain relief. For example, in bullous keratopathy, it can be managed with soft bandage contact lenses because it relieves pain by protecting the exposed corneal nerve endings from the shearing force of the lids during blinking. And the lens may also flatten bullae and to diffuse fine epithelial cysts. Another use is filamentary keratopathy. There is pain in filamentary keratopathy and resistant to the topical treatment will usually achieve some relief from soft contact lens wear. Other indications of contact lens include Thygeson superficial punctate keratitis, in which there is pain and protection of the corneal epithelium from aberrant lashes in trichiasis. Also used as a temporizing measure in entropion prior to definitive surgery. Other uses are preservation of corneal integrity. For example, in dysmetocele, it can be temporarily kept with tight fitting large diameter soft or scleral lens to prevent perforation and encourage healing. Another uses for splinting and apposition of the edges of a small corneal wound. It can be achieved by means of a contact lens. Slightly larger perforations may be sealed with glue, followed by insertion of bandage contact lenses to both protect the glue and prevent irritation of the lids from the glue irregular surface. Other miscellaneous indications are ptosis probes, ptosis probes to support the upper lid in patients with ocular myopathies. Another uses for the maintenance of the fornices to prevent semblebron formation in cicatrizing conjunctivitis. Another last uses for drug delivery, enhancement by a hydrogel lens imbued with topical medication, occasional indication. Now the complications of contact lens use. The first one is mechanical and hypoxic keratitis. The pathogenesis: there is insufficient oxygen transmission through the lens. A tightly fitting contact lens that does not move with blinking, it will impair tear circulation under the lens. So this is exacerbated by lid closure if the lens is worn during sleep. So then the hypoxia will lead to anaerobic metabolism and lactic acidosis, which will inhibit the normal barrier and pump mechanism of the cornea. Another complication is superficial punctate keratitis. So the mechanical and hypoxic keratitis will lead to superficial punctate keratitis, which is the most common complication. So the pattern of the keratitis may give a clue to etiology. For example, staining at 3 and 9 o'clock is associated with incomplete blinking and drying in rigid lens wear. Next is tight lens syndrome. So it is characterized by indentation and staining of the conjunctival epithelium in a ring around the cornea. Acute hypoxia, characterized by epithelial microcysts. There is necrosis and endothelial blebs. Very painful macroerosions may develop several hours after the lens are removed following a period of overwear. So this is acute hypoxia, and there is epithelial microcysts. Then there is chronic hypoxia. It may result in vascularization. Vascularization and lipid deposition. Superficial peripheral neovascularization of less than 1.5 mm is common in myopic contact lens wearer and can be monitored. And the treatment of all these is depend on the cause, but may involve increased oxygen permeability by refitting with a thinner lens or refitting with a gas permeable rigid lens or a silicone hydrogel soft lens. Thinner lens, gas permeable rigid lens, silicone hydrogel soft lens, or modifying lens to fit to increase movement and reducing lens wear time. Another complication is immune response keratitis, also known as hypersensitivity keratitis. Hypersensitivity response is due to bacterial antigen or due to chemicals which are used in the lens and can lead to development of sterile marginal corneal infiltrates. Sterile marginal corneal infiltrates. The mechanism is thought to be similar to marginal keratitis. So there will be redness, mild redness and infiltrates in the margin, and there will be no or minimal epithelial defects. Treatment is cessation of the lens wear until resolution occurs. Topical antibiotics, steroids may be used in some cases. But if the diagnosis is uncertain, treatment should be that of bacterial keratitis. Another complication is toxic keratitis. The pathogenesis is there is acute chemical injury, and it is caused by inadvertently placing a contact lens on the eye without first neutralizing toxic cleaning agents such as hydrogen peroxide. The chronic toxicity results from the long-term exposure to disinfecting preservatives, such as thiomersal or benzalkonium chloride. Benzalkonium chloride. The signs: there will be acute pain, redness, chemosis, and the lens insertion, which may take 48 hours to resolve completely. Sclerization and scarring of the cornea and limbal conjunctiva in chronic cases. Treatment involves switching to daily disposable lenses or using non-preserved disinfectants such as hydrogen peroxide. Suppurative keratitis. The contact lens wearers is the greatest risk for the development of bacterial keratitis. The risk is probably least for the rigid contact lens. Bacteria in the tear film normally unable to bind to the corneal epithelium. So then how bacteria attach? Bacteria attach follow an abrasion or association with hypoxia. So bacteria then attach, they invade the epithelium, and the microorganisms, they are introduced onto the corneal surface by poor lens hygiene and also the use of tap water for rinsing.